righty. I'm Ana Tovar. I'm a clinical psychologist, and I'm the behavioral science faculty for the York Hospital Family Medicine Residency program. And Larry invited me to talk to you about a project that I and one of our third year residents worked on over this past application cycle. So I'm assuming all of you can hear me fine. If Larry, if I could share my screen, I have a short PowerPoint to share with everyone.
You should be able to share it now.
All right, I'm assuming everybody can see this, and let's hope that we have no snafus. And there we go. All right. So with this year being extraordinary and requiring that our recruitment efforts and interviewing be done virtually, our program has had a pretty good run in terms of successfully being able to recruit a number of underrepresented in medicine residents over the past, I'd say the past 4 or 5 years. We've done very, very well in that we've had 2 of 8 in most years matching with us, and they've either been African American or Hispanic, usually African American or Black. And given that our clinic population in our community is about a quarter, close to a quarter African American, and another close to a quarter Hispanic, many of those being Spanish speaking, it's incredibly important for the health of our community. And for our residency, the richness of our residency and the education that we can offer, if we have a diverse group of residents that reflect our community. So I was interested in, let me see, what's the problem with advancing here? There we go. I wanted to make sure that we kept the focus on matching at least the results that we've had in the past, but hopefully even increasing the number of URIM, specifically African American or Latino physicians. And with regards to Latino physicians, we were really hoping to find some that were fully bilingual, fluent in Spanish. And I wanted to evaluate the impact of virtual interviews during this particular application cycle and compare it to last year. I was actually a bit worried that we might get more applications because of the ease of being able to apply to a number of programs and the removal of barriers such as cost and travel time. Now, on the one hand, that might be beneficial to many underrepresented minorities that might not be in the best economic circumstances. On the other hand, it would be an advantage that everyone equally would benefit from. So my questions were, would the total number of applications increase? Would we also see a concomitant increase in the number of applications from African American and Latinos? And how would our recruitment efforts and matriculation be impacted? So what we did was examine and compare the total number of applications, how many passed our initial screen and were offered interviews as compared to the previous year, and break it down in terms of demographics, how many non-URIM, how many African American, how many Hispanic. And I'll report on our results. And the other thing that we were interested in, because we also tried a number of other initiatives, which I will fill you in on later. We wanted to know what the interviewees thought about the whole virtual process, and particularly some updates to our website. So we did ask them to complete a Survey Monkey and provide us with some information on what influenced their decision to apply to our program. So what we found, the first question to remember is, will the total number of applicants increase as compared to the previous year, because those barriers such as travel time were removed? Well, as you can see here from the table, the total number of applications as compared to the 2019 cycle was actually slightly lower, 270 as compared to last year's 284. However, the number of individuals in that pool that met our selection criteria for interview was actually dramatically higher. So just a little over half met our initial criteria and could be considered for an interview slot. 139 as compared to last year's 99. As a result, we needed to create more interview slots because we had more qualified candidates than we had time to interview. We usually interview 3 on the days that we interviewed. Every day or every time that we had an interview day, we increased that number to 4 candidates. And even with increasing the number of days and interview slots that we made available, there were 19 qualified candidates that we did not accommodate and we did not offer interviews to. Now, specifically with regards to the African American, Black, or Hispanic candidates, there was very little change in the number of qualified candidates that met our criteria between the 2 years, or the 2 application cycles. This was true both for African American candidates as well as for Hispanic candidates, as you can see there. And the numbers have always been low. As you can see, you also have to account for people dropping out at the last minute, canceling appointments, and those who, following an interview, we decide not to rank. So looking at the African American Black candidates, you can see that in terms of the total number of applications varied very little. It was 27 previously. We actually had 2 less applications this year. These are US grads now. And so we offered interviews to 8. We had a cancellation, interviewed 7, ranked only 4 in the previous year. And a little bit similar in this year, we had only 7 candidates and that met our criteria and that we invited for interview. 2 canceled. So, you know, that little bit of attrition that you have to account for can really make an impact. Unfortunately, we ended up interviewing 5, but thankfully ranked 4. You'll notice that I added an IMG here because that's also one of the initiatives that we tried in order to boost the numbers of URIM in our pool. So looking at the Hispanic group, again, with regards to total number of applications from those who identify as Hispanic or Latino, little change. And again, the same drop, we had 2 less this year as compared to last year, and offered interview to, you know, about the same. 2 canceled or declined in both years. And we ended up ranking all 6 of the ones that we interviewed. And we also had 2 promising IMG candidates. And because we do have need of more Latinos, particularly bilingual Latinos that can serve our Hispanic population, we also looked at the candidates that were from foreign medical schools and also interviewed and ranked 2 IMGs. So here are the actions that we took to promote recruitment. And since we didn't have a greater number of URIM candidates as compared to the previous year. We needed to increase the chances that we would matriculate and find, or at least reach some sort of equivalent type of result when all was said and done. So we ensured that all qualified URIM applicants were offered an interview. You'll recall that we had more candidates that met our criteria for interview than we had available interview slots. So because we made it imperative to try and match our previous success, then any URIM that was that was available for interview and that we could interview was offered one. We, as I said before, we did look at applications from IMGs and also included some in the mix to account for attrition. And characteristics such as Spanish fluency helped put someone in a very, very favorable spot when we were considering the match. Most of our URIMs were placed in very competitive spots. Since we've done fairly well the past 3 or 4 years in terms of filling at about a third or a little over a third of our rank list, we know how important it would have been to place them within striking distance in case we had another very good year. Our results were, I'm happy to say, we matched with 2 URIM out of our 8, both Hispanic this time. And so we've matched our previous result. But I have to say that this was due to these intentional efforts, as well as I think some additional ones that I'll discuss in a moment. You don't, bottom line is, given my experience, you need intentional and deliberate action because the pool is small right now, and you have to increase the chances that you will also be seen as favorably to these candidates as they appear favorable to you. So the other initiatives that we took that I think really made an impact was a website redesign. We have a very diverse resident body, and we wanted to showcase it because it's one thing to say, it's one thing for a program to say that it values diversity and it welcomes folks from all backgrounds. It's another when you have, and you can showcase evidence that we do stand behind what we state. And for underrepresented minorities, it is extremely important for a prospective resident to look at their future colleagues and see people that look like them, or imagine themselves working alongside people that appear simpatico, people that they would appear to have something in common with. The question that most will ask themselves will be, do I fit in? And will I feel comfortable and accepted in this particular environment or in this residency? So we made it a point to make sure that we showcased our very diverse group of residents. I, as the only person of color on the faculty, made sure to connect with every African American and Hispanic applicant whom we interviewed. And we also sent, as I said before, that Survey Monkey to everyone and asked them about 7 questions regarding factors that they considered important in a residency, factors that may have influenced their decision to apply to us. We were kind of interested to see, even though the numbers were small, so we didn't subject it to any kind of statistical analysis, whether we'd see any differences between the responses of URIM versus those who did not identify as URIM. And that really wasn't the case with our question of, what were the top 3 factors that you think influenced your decision to apply to our residency program? They were location, curriculum, and what I didn't list here were things such as website or interaction with the residents. And as I said before, our website was one that really showcased our diversity. And the interaction with the residents, we made sure that at the pre-formal interview, the night prior to the formal interviews, they had a chance to have a virtual dinner with a group of residents, and we received a lot of feedback from the applicants about how comfortable they felt, how much fun it was, that it was the best resident, for many, it was the best resident dinner that they had had so far during their interview season. So do you have any questions about what we did and or what we continue to do, or what our future direction might be, given what we've learned about this particular cycle? I hope that we don't have to do virtual interviews again. And hopefully that won't be the case, but it might be a hybrid kind of thing this year, who knows? So I think we've learned a lot from the process, and I haven't talked about this with the other faculty members, but again, because travel time and cost can be such a barrier for folks who have who are less well off, it could be something to consider that we offer virtual interviews as an option for those who might have an interest but don't have the resources.
Thank you,
Hi,
Anna.
I have a question.
Go ahead, Mike. You
Michael?
can ask first. I'll follow you.
Yes, no, I was just going to say, when I just wanted to, for the virtual dinner that you did the night before for your applicants, it sounds like you had diverse residents made sure that they attended, or that they were there at that dinner, is what you were saying, right? They gave it high marks because there was a measure of diversity at the dinners with the residents. It wasn't just a homogeneous group.
Yes, it was not a homogeneous group, and we debated as to whether or not we wanted to make it mandatory that they meet as a group, so that they're all on one screen, which they did, and I think that worked very well, because people could see the natural ease with which they interact with each other. So and that's more difficult to capture when everyone is in their little square.
Okay, great. Thank you.
Sure.
And Anna, I was going to ask, I know at our resident dinners, you'd have a group there, that hopefully was a representative sample of your various types of residents you have. What I would typically do after that is assure that one of my underrepresented minority background residents followed up with the URIM for a one-on-one, and they'd make a phone call to them, because sometimes it's uncomfortable to ask questions or bring that issue up in a group meeting. Did you have that happen also, and how'd that work out for you?
Well, I would say that in the majority of cases that does occur. And maybe next time around, because I collect data on this every year, I'm going to keep better track of who followed up with whom. But yeah, that is.
I would feel more comfortable, I think, if I were in a minority situation, talking offline, one-on-one with someone who might have had a similar experience that I'm worried about, and get their perspective in that. So yeah, I think it's worth a try. Well, I agree with your idea of like blending maybe next year virtual interviews with face-to-face. And it's going to depend on some of the qualifications of the candidate, obviously, and maybe you've also had interface with them before. They've done a rotation with you as a student or something else. So you may know them well enough that you figure you can do a virtual, and then you don't pull them off rotations and give them travel expenses, and because they only get so many travel days as a resident, or so much time when they can travel during rotation. So to me, I like a student who's worried about missing rotational experience for too many interviews. That's the kind of person I'd like to get into my program, who's afraid they're going to miss important educational information. Those are the hungry for education people you'd like to have. So I think you have to judge on an individual basis whether to use that. But I think it's sort of like doing patient care. We should not do all of our visits virtual, and we shouldn't demand that all of them are face to face. Look for that right mix of the two that we have to get the job done.
Mm-hmm. Agreed.
Just as a heads up on I'm pretty sure that we are going to be face to face in Pittsburgh this October 8th through 10th with a residency fair. The issue of a virtual residency fair is not one we fully resolved. It's an expensive proposition, actually.
Yes.
But I think the chance for just mingling, or chance conversations, bumping into somebody in a presentation that you're both in because you're passionate about a topic, those kinds of random connections, that serendipity, I think is an important element as well.
Absolutely.
Hey, Anna, I'll ask you a slightly off topic question, but a question anyway.
Yeah.
How do you feel about students coming from an accelerated training program where they only have 3 years maybe of medical school instead of 4, and they've accelerated them because they're going into primary care ultimately as a decision? Did you see any of those this year, and how do they compare with your 4-year candidates?
I don't know for sure whether we've seen any from an accelerated program, to be honest with you. It doesn't ring a bell that we had any discussions among the faculty or even in our match meeting, comparing like apples to apples, or whether anybody had any concern about someone lacking in experience. We've certainly had conversations about how best to evaluate very early on this incoming class, because COVID has cost them some clinical experience that they may be behind the 8 ball in some areas where they weren't before, previous classes weren't before. So we are asking them to self-assess certain skills. So we are sending them a questionnaire, and we do an OSCE early on, where it's a full morning of all kinds of stations where we kind of get an idea of what their suturing skills are like, their knowledge about social determinants of health, for example.
I think having them demonstrate competence or express to you areas of concern makes perfect sense after this COVID year, so you can get a better feel for where they're needing to shore up perhaps experience, and then get that to them during their first month, so then they can with confidence become an intern and function at a higher level.
Yeah, absolutely. Well, I would think that any of those students in that accelerated program would really be at a disadvantage this particular application cycle, or this coming application cycle.
Just a comment, Ted, there aren't actually that many of them. The nearest one to where Anna is Penn State Hershey's, and that's only 3 or 4 students per year, and there aren't that many of the accelerated programs, so the numbers are actually pretty small.
Got it. Yeah, that's good to know. I hear about them all the time, but I'm not sure how widespread they are. It sounds like they're not very widespread in the schools yet.
I do want to make a quick mention about another initiative that we're very excited about, although it's not going to bear fruit for a number of years, and it may not even bear fruit for us in our program, but it's important nonetheless. Some of our family medicine students and a couple of IM residents started a social engagement and community engagement group. And right now they're sort of struggling to find more members. But the bottom line is that one of the things that we've been able to accomplish, because I'm their faculty advisor, is that we've partnered with a local community college that has a scholarship program for minority students that have an interest in the health sciences. So we've had a couple of, we're basically adopting them as mentees. Not necessarily because we want to develop them into family physicians, but we can develop them into, a radiologic technician or a nursing assistant. They, as the previous presenter said, there are so many. When you think about it, our communities have all the resources that we need. It's just that we're not mining them in the correct way. And we have to look at things from a totally different vantage point to be able to see the gold that's there and help develop the talent that we have. Not necessarily to go all the way to medical school, but to deal with the helping to heal the problems that are truly affecting the health of our communities in ways that they can best do, and in the ways that only they can do. So, so yes, our resident engagement group is called Thrive, and that is one of the projects that they are working on.
So, Anna, if I can make a comment about that, if you think long term, so these young people that you help to become radiology technicians, they grow up, they have a family, they value education, their children maybe aspire to go beyond where their parents are.
Absolutely.
And sometimes it takes 2 or 3 generations. And if you look at immigrant families, and you can go back to the Irish where I came from, you can go back to the Italians, you can go back to any group. It's one generation building upon the past generation. And that's what we've, in my opinion, we've lost. So I really commend your group, and I'll reach out to you because I'd like to learn a little bit more. It's a nice model that it's a long-term strategy. It's true, but it's better than no strategy. Much, much better.
Absolutely. And we're not just investing in our residency program, we're investing in our community. So
exactly.
That's the way, and that's what family medicine is all about anyway.
Yeah, there are a number of, I was going to mention, Larry, there's a number of pathways programs that reach, into college and down into high school, and they're looking for mentors to work with. And as you said, Anna, it doesn't mean they're going to all become like family docs, but they're looking for mentors in medicine to at least help these kids, encourage them to get past the barriers that they face. And they especially want mentors who look like and are from backgrounds like these students who are from disadvantaged areas, so that it gives them hope that they too can move past their current surroundings into something that they dream of, but they aren't sure is really possible for them. So encouraging your residents, your faculty, and others to serve as mentors with those type of upstream programs that exist in many different schools, it just makes perfect sense, I think, especially for family docs, because they're so broad in their interests. And I think they're so broad in the type patients they're comfortable with, they can enter almost any situation, I think, and be of value to that student to point out the advantages of the various health professions the student might be considering. In fact, you can probably pick up on what they're most interested in by spending time with them and then help encourage them in a direction. So I'm with you, Larry. I think, we can, if we do more mentoring of these students and connecting with them earlier on, especially when they're from underrepresented areas, that's going to, I think, be a huge benefit.
So, Dr. Potts, I think that these are all our presentations. We have a little time for brainstorming now. We have a much reduced audience.
I'm always so amazed about how fast this time goes by. And I'm super excited. The next time we get together, we have the opportunity to bring a larger group together at the meeting. And I think we should think about what would be useful doing in Pittsburgh at the annual meeting, and thinking about what kind of time and space do we want to do something pre-conference or during the conference. I think there's always conflicting reasons for doing one or the other, but if we do a pre-conference, then it's likely to be a smaller group again. If we do it during the conference, then everybody has other places to be too. So I'm interested in the group's thoughts of who will be at the meeting in Pittsburgh, who will be able to join us. It would be nice if we could do it in a hybrid way so people can join regardless of whether they're at the meeting or back at home. I don't know, Larry, what are your thoughts? Do you have a vision of what you'd like to see?
Oh, yeah, I'm glad Ashley, I see Ashley rejoining us. Whether it's a pre-conference or during the meeting, that's one issue. I think the other issue is, are there some specific things? You know, we've held a number of these sessions now. We've had some very innovative ideas and projects that have been presented. And I think the next issue is, let's start thinking about some specific actions we might want to take. So I wrote down a series of ideas that occurred to me as I was listening to people present. And Ashley, one of the things that I thought of is your connections with HOSA. We could also invite HOSA community to the meeting. We could also invite the local pre-health advisors. Kathy Shelton's had to leave, but she is very, very interested in this long term. And I think there are a bunch of others. So Penn State, for example, is connected with something like 25 or 30 colleges, particularly in rural communities, that are very interested in their students being able to compete for medical school. We could invite those people to the meeting also, along with the HOSA students. One of the other things, there are a number of family physician deans of medical schools and associate deans, even larger number of them. We might want to hold a session, Stacy, with them, maybe just a 1 hour session in a couple months, to try to get their perspective on this whole issue. I appreciate that if you're a family physician and you become dean of a medical school, you have to be careful about looking like you're too biased towards family medicine. I've seen that many, many times. But behind the scenes, these are still family physicians. And when I talk to them, they will tell me, you know, the secrets or the little things that they can influence without looking too heavy-handed. But I think we could begin to partner up with them. We could do that in a virtual way, since they're all over the country. One other thought I had, you know, Art Kaufman made a point. In New Mexico, they have a statewide goal for increasing the primary care workforce. If you remember, he talked about how many family physicians, how many additional family physicians, how many nurse practitioners, how many PAs, et cetera. Why doesn't that's the only state I've ever heard of that has goals at a state level. Because I do think Hannah's right. You got to get down to the state level. That's really where a lot of action can occur. And so I think we can encourage, whether it's through the AAFP to the state chapters, or, you know, I don't know, Ted, here in Ohio, you know, do you think the folks at the Ohio Academy would want to take that on to come up with some kind of projection? I mean, the data is, I think, pretty well out there. It's a matter of just drawing it together and getting some consensus.
Right. Yeah, it seems like you have to hit a crisis level almost for people to respond to that need, Larry. I think New Mexico is very much at a crisis level with their lack of access to care. I think Ohio, if you look statistically using the Graham Center's data, they don't have that same level of anxiety that's produced with the data that's out there about primary care, because they're not looking into the future, they're looking at the here and now, which doesn't look near as bad as I predict the future is going to be. So yeah, we could certainly ask our state academy and see if they wouldn't, because they have a whole group that works on policy, and see if they'd be willing to work with us. I certainly believe that.
Stacy, what about Massachusetts?
Yeah, you know, as we have this conversation, I realize I don't know that world. I don't have those connections. We have Commonwealth Medicine within our department who does a lot of health policy work for the state, and certainly being the state medical school, there's a lot of that work going on in our school, but I'm not involved in that world. It's a lot for me to learn about.
That may be a group to ask, Larry, would be those executive vice presidents of the state chapters, and say, how do the chapters perceive this as a need, and are any of them working actively towards addressing this the way New Mexico and Indiana did too? Of course, they created new primary care slots based on the data that Hannah presented to that council, but the data drove the decision. My problem in Ohio was when I looked for the data, we didn't have a similar data system to go to that we could trust. And that's why I made that point about having minimum data sets that are the same, because as soon as I did go to the state and say we needed, assistance, well, so did everybody else. Every other discipline was right there with me. And they're all saying, we've got data to show that we have need too. Well, their data came from all different sources. And with all that confusion, people have trouble making decisions. Legislators, they're not that smart. They only know what people throw at them. And I'm going to tell you, it confuses them more than helps. So I think Hannah's on the right idea, which is get your data, make sure it's uniform data that you're working on.
Stacy, can you take over?
Yeah,
So,
absolutely.
go ahead. Hey,
Um,
Stacy, I wanted to recommend one other consideration, and that would be innovations in the House of Medicine to get at this issue of workforce. And the reason I mention that is because Hema's on this call, and to me, Metro Health is one of the most creative organizations I've ever seen, especially with their bringing a high school into their hospital. So they're training kids in a hospital. They're doing basic high school education, but then they're also connecting these kids with health workers all over the organization. I mean, how genius is that? And by doing that, they've upped their graduation rate tremendously for these kids that all come from the inner city and were at high risk. So why didn't that happen everywhere? I don't know. I mean, Heyman, I don't know how connected you are with that program, but I thought it was a great idea.
I agree, it's a great idea. I'm not involved in the program, but the Department of Family Medicine also has a school health program where our residents and medical students go to the local school district and provide a healthcare vaccination. I think that, those are one of the areas we can utilize. This whole session has been eye-opening for me. I'm just trying to absorb all the information, what all of you are speaking. I couldn't add much. But I think even as you had mentioned, I had a couple of my patients, like pediatric age group, who have told me like they want to become doctors or pediatrics or nurses. So, starting at our patients while we are seeing them in the clinic, as well as when you're doing the school health programs. And I think mentoring is very important. So, having people, even nurses, MTAs, physicians, reaching out to the high schools, to the middle schools, and telling them there is a career in healthcare and what kids can do when they graduate. Educating them, because oftentimes they are most of these parents might not be educated or might not invest in education. So I think we have a lot of areas where we will be able to help our the school children.
Yeah, well, I still remember when I was director of health, I had a call from a medical student at Harvard, and he said he wanted to do a summer rotation with me at the Department of Health. I said, well, why'd you contact me and do it now? he said, because in the 5th grade, you encouraged me to become a doctor. And that was at an inner city clinic in east side of Dayton, East Dayton Health Center. And he was dating a girlfriend who was at a lecture that I had done to the medical students. And so he got a copy of the lecture and contacted me. We spent the summer together after that. But I never guessed in the 5th grade when I encouraged him, and you know, he's from a minority background and he was an inner city kid, that it would lead to that. So you know, I'm convinced that we can make huge differences in people's lives. We just don't want to miss the opportunities that are in front of us every day. But we don't think of them, or we don't think of ourselves that way sometimes. And I sure encourage everybody to see themselves as a miner out there of talent and potential, who propels kids into a better place than they otherwise would be.
Yeah, I agree.
So I love what you're doing at Metro. I think having a high school in a hospital is just genius in a high risk community.
Yeah, this sounds like an amazing program that I've never heard about before. I don't know, Hema, if you know, I mean, this would be an example of somebody we could have present to this group, right?
Yeah.
If we can get some connections with that, because you're right, Ted, why isn't this everywhere? And, you know, when you think about vocational high schools, health occupations careers are really important within that space. And this sounds like an innovative way to do that.
Interesting you're talking about it. The clinic where I work now is within a school. So the school had given us the land for Metro Health to build a clinic. So my clinic where I work currently is within the school system, so that we can provide health for the local school children.
Yeah, and that's awesome. And again, like just breaking down those barriers to access by being where the kids are.
Yeah, and my Dr. Alexander, who's the chair of family medicine, she's involved with this school health program. So I can reach out to her and ask her to reach out to Larry or to you.
You know Chrissy very well, so yeah. So Larry's worked very closely with her.
We've got ins with Chrissy. That's great. So many interesting ideas to think about. What else? As I'm listening to folks, I wonder about, again, thinking about folks from state academies that might be interested in you know, being involved in our discussions. Jen Sparks and I have been working here at the state to sort of build a consortium under the Mass Academy of Family Physicians at the 4 medical schools to try to, and the different residency programs within our state. Our state is interesting in that there's only 5 residency programs and only 4 medical schools. So it seems very simple to bring those folks together. And we have done some interesting projects recently that I think have built some pathways for that, particularly around the opioid crisis. We, had statewide initiatives where the governor essentially said, you 4 medical schools need to work together and build a curriculum so every medical student is trained in this period, end of discussion. And it was done. And I think, again, in a state like ours, we need to be working more collaboratively. So anyway, so Jen Sparks and I are working on student interest and thinking about how the 4 schools, FMIG groups could work together. And especially in this Zoom land that we're all more familiar with these days, it seems a little simpler than it was in the past. But that's all under the state academy. So I wonder if there are ways to show off how state academies are supporting workforce agendas and invite them to our discussions in some way.
Taking that note down.
And certainly, I know the Pennsylvania Academy for the Pittsburgh meeting is a slam dunk. We can get them involved. So, right, Larry?
Well, yes. I mean, we've got Molly Talley sitting on our board. And, what's interesting, though, is when you get down to, as Ted was saying, at the actual level of what are they actually doing, that I have to say, now I don't know intimately each one of the states, but I can tell you, and I hope people won't repeat this, but here in Ohio, I'm underwhelmed. There's so much more that's within their reach that they could be doing, but it's just not, there's too many people worried about this is going to make extra work for me.
Well, I feel like each academy probably has somebody on their board who
Yes.
owns student interest. And that's Jen Sparks for the Mass Academy. She's kind of taken on this interest. And I wonder about the other states and connecting with each of the academies and saying, who is it at your academy that's working on student interest? And then being able to do a direct invite, because the academies could learn just like us from each other on best practices.
So that strategy I like a lot. Ted, without naming names, some of the executive directors, they're not the right person. Let's just say that. But finding that person, like Stacy is saying, who does have that passion in trying to work from that I think could work.
Yeah, well, I think a lot of them set up strategic plans and they put together their work prediction that they need. And when you come to them and you say, but you also need to include student interest, they go, well, hold on a minute. That's not in our strategic plan. We don't have clear defined roles for someone to deal with that. And so they're hesitant to add that on, Larry. And I get it. They have limited workforce, right? They've got limited income. They live off the dues that members pay. So I get the reason that they're not all jumping at opportunities like this. On the other hand, we need to make it a priority somehow. So that's where I think, finding a champion in each state maybe who might be willing to work with the state academies and make sure that this stays a priority for them and gets put into their planning mode is really important. Because if it's not in the plan, it won't get done and it won't get funded.
And further, I think Ashley has mentioned before that there may be some national funding for different state projects. So I think one of the messages from today's discussion is like, think big, but act locally, like really think about the state data, the state workforce, and sort of the state energy. But I think having the resources from the National Academy and the work that they're doing in terms of, we need more family doctors, America needs more family doctors, and think about, for each state, Massachusetts needs more family doctors, and being able to make the specific argument and have the Mass Academy use the National Academy's resources to make it a statewide effort. And for academies that don't see that as part of their strategic plan or mission, they should talk to Ashley, because it is a major strategic initiative of the National Academy. So as a state chapter, it seems that they should be following suit. And I don't know if Ashley's juggling small children right now and not able to speak up, so I'm speaking for her. But I know this is important and important for the state. There you go, Ashley.
Hi, yeah, I am listening and also trying to, I do have a small child who is not very quiet near dinner time, and I apologize for the distraction. My husband ended up having to work late. He's a police officer, so we can't always predict these things. So I wasn't planning to, he was supposed to be here to cover this evening, but that's the way things go. Yeah, our chapters do always have the resource to fall back on of what's called our, I think it's called FMLC grants. And I might be getting my acronym wrong on that, but we do have, the AFP Foundation has funding to support our state chapters to take on efforts that are related to our strategic priorities. And workforce is one of the big ones in a lot of our states. Ohio has done a lot. The externship program, the summer externship program that the Ohio state runs, is supported by the FMLC grants. And then there are a lot of other great examples of that. And Stacey, I appreciate the connection with Jen Sparks. I had met her, I think probably at an FMEC meeting before, but I was able to connect with her one-on-one after our last one of these meetings and talk to her more about leading those efforts in Massachusetts. And I agree, we can definitely leverage the efforts of our stakeholders and members and volunteer leaders all across our chapters. From a chapter staff structure, they are tiny to pretty large and all in between. What Pennsylvania has is not typical. What Pennsylvania has in terms of their staff structure is not typical, and what they have in terms of just the unique value of Molly Valley is also not typical. But there are some of our other states, especially our larger states, that do have more staff that are dedicated to that work. And then a lot of them run this work through their foundations. And I think that I'm hoping that with the programs that we build out nationally, especially with our kind of equip our role models to be those role models to high school students, to college students, to medical students, the resources that we are hoping to build. And we're kind of playfully calling that our ambassador program, like creating a network of family medicine ambassadors who are equipped to speak confidently about the future of primary care, the future of family medicine, and also speak confidently about what careers in family medicine look like and what the educational path looks like. We're hoping that those resources would be available then to really any of those influencers. So our members who are family physicians talking to their patients or talking to their students if they're working at a medical school or if they have students that shadow with them, but also pre-health advisors. One of the amazing groups that we're getting to connect with because of the work we're doing with HOSA is all of these high school advisors who are their HOSA, chapter leader, and also state advisors with HOSA that are working with chapters across their states who are educational professionals. And now they can be informed about family medicine because they are responsible for bringing all of the programs that HOSA offers to their states and to their schools. And if they have students that participate in our program, they have to have some level of awareness and education to be able to support those students. So we're really working toward developing this robust set of advisor resources, if you will, ambassador resources. And I'm hoping that that will help our chapters and anyone else who has some energy for this work to be one of the tools in their tool belt that they can leverage. And then the other really, I think, strong set of alignment I'm hearing in the way that these conversations are continuing and the work that we're hoping is around that student choice learning and action network. So helping medical schools. And I think about Penn State, from the conversations we've had today, like, hey, we're trying everything. We're doing all the things that the evidence says. What should we be doing? Helping those medical schools that have some energy for this work and who are really trying to figure out, what do I prioritize? Where do I focus my efforts? Helping create that network that can and leverage the evidence to best kind of inform and support and learn from those efforts. I think somebody mentioned, while we were talking about Pennsylvania, the Commonwealth Medical College, or Geisinger now in Scranton is another good example that they have kind of some of the right things happening and changing in their institutional environment to prioritize family medicine, workforce development. And so being able to work with the schools that have those windows of opportunity or the right ingredients kind of coming into place in terms of leadership or curriculum change or state level, crisis level conversations to be able to leverage those opportunities in a way that's collaborative and supported nationally. So I feel like I'm starting to ramble, and I'll stop rambling, but I'm seeing a lot of strong connections. And what I'm wondering is, could you all or us together be some of the starts for some of those things, some of the some of the testing grounds or pilot programs for some of the things that we could hope could even extend nationally.
So Ashley, I think you made a good point, and as I'm thinking, what would we do, Larry, with state chapters? Why don't we highlight their strengths? What are they doing that's particularly good? For instance, with the Ohio chapter, their summer externship is a model that many other states are trying to duplicate, and they'll have probably 70 students this summer who will spend time in family doc offices. These are first-year medical students going to second-year medical school before they get into clinical rotations during the summer. So they're spending, a month on average in a family doc's office in Ohio, usually back home. So that's a great program started by Leroy Rogers. Again, you had a champion for this, and the champion started it up but he put his money where his mouth was. He put the money in to fund this when it first started, and then it's grown ever since by member contributions to our state foundation. So they found a way to do it. I think that's half the battle, is figuring out how do you fund these things. And not only is it a good idea, but how do you sustain it? That's been sustained for decades now. And those are the kind of things I think all the chapters would be glad to share what they're doing well. And then other chapters that are there can learn from each other. I guess I'd much rather take that approach versus say, why aren't you guys doing more? And they'll find a way.
Right. I think just sharing those best practices will really inspire everyone to kind of pick up another tool. I'm curious about the Ohio externship program. Does the funding go to stipends to the students or stipends to the family physicians hosting them?
Goes to the students. So they get a weekly, the students do this in lieu of a summer job. So they get a stipend. It's not as much as they could make probably in business, but they make a stipend. And then the preceptors don't get paid, they volunteer. So, but we get plenty of volunteers all over the state that are happy to have students come in. And especially if they're from their community, they're real happy to have them come in because they're looking for docs in those communities. So they're very willing to volunteer.
That's great. Okay. Other ideas and any thoughts about pre-con versus during the conference? Does anybody have any strong feelings about that? And kind of, I mean, the other option too is to have several different events that just sort of fall under the umbrella of Workforce Challenge, and then maybe, you know, have one event that's focused on state academies work or that sort of thing, and another event that's focused on, you know, some other innovations, and sort of sprinkle them amongst.
We could definitely do that. We could have a pre-conference and we'd figure out what the target, you know, topics were for the pre-conference, and then we could have something during the meeting.
And there may already be things kind of within the meeting, scheduled within the meeting, that would fall within this theme. You're making faces, but there might
much.
be.
Not much. No, I've been through all the submissions.
Yeah. But if there were even a few to just highlight as part of the theme.
Yeah, we could.
Because I imagine like there must be some around diversity and inclusion.
Oh God, yes.
That seems like a hot topic. So that's recruitment and pathway to medicine sort of topic sometimes.
Yeah, that's true.
And, you know, one of the things that I think, Larry, this came from a discussion you and I were both on around pipeline versus pathway to medicine. And, you know, it's probably better to think about a pathway.
Well, I think so. So just so everybody knows, I got one of our FMEC board members sent me a message and expressed concern about using the term pipeline because some Indian tribes may be offended because pipelines are what are used to destroy their home turf, so to speak, and they might be offended by the term. You know, I've had discussions with Randy Longnecker and others about the use of the term pipeline. He doesn't like it either, but for different reasons, because he said, look, it isn't a pipeline. It is, you know, and I think the idea of pathways to family medicine, pathways to health careers, you know, that's a nice generic term. So I've tried to train myself not to use the term pipeline, and but everybody understands. As soon as you say it, everybody knows what you're talking about. That's the challenging piece. So we'll see. But I just thought everybody should be aware of that.
I also feel like in my mind, I respect that the inclusivity and trying to avoid any offense to our Native Americans. But the other thing that I think about, just visually, being a visual learner kind of person, is that a pipeline is like hard set way to medicine, where a pathway can really be individualized and can be a little more meandering, which I think when we're talking about, because if you think of a pipeline, it's like you start at point A and you end up at point B, and you go down a hard lead pipe to get there. And that's not what we're looking for. We're looking for people who have meandering pathways along the way and just want to open doors for people to come in from all different ways. So that's why I like Pathway a lot better.
And they're more likely to choose family medicine. You know, if they're go from point A to point B, kind of, you know, the gunners, so to speak.
He ends up in dermatology or anesthesia.
Yeah, those things, yes. So yeah, no, I like the term pathways also, but I just thought everybody should be aware of, you know, that background issue.
Yep, and being a fisherman, I always use upstream. So, you know, to me, it's you know, pretty generic and mild, and it doesn't restrict flow. It actually has lots of water coming in and places to go and islands and all those other things that are included with that. So, yeah, I get it, Larry. Be careful with the words.
There's a beautiful book, Ted, too, called Upstream, and uses this, I want to say allegory. It's some sort of story about some people walking by and seeing children that are kind of drowning in the river, and they run and, you know, save these children, but children keep coming. And one of the people says, well, I'm gonna, you know, just starts to leave. And the other person says, what are you doing? There's all these children to save. And I'm going to see who's throwing the children in the river, right? The idea of going upstream and figuring out what the bigger issue is up there that's causing so many children to be drowning in the river down here.
I've heard that.
Yeah. And the book is really well done. I can't think of the author right now, but it's about how we move towards a more proactive approach to fixing the healthcare crisis. And it's hard. It's hard to leave the children drowning in the river down here to really build something up there.
So Tamara Jones used that metaphor or allegory or whatever it is in her talk at her plenary session last year. You know, keep going back. She had that picture of people going over the cliff and interesting.
Yeah.
So what I'm going to do is I'm going to dictate my notes. I'll share them with everybody. To me, this is, you know, if we care about population health, the only thing that our medical schools can do that really will improve the population health is more family physicians. That's it. All the other courses on population health, they won't increase health equity. They won't improve quality. They won't improve longevity. They won't improve morbidity or mortality. More family doctors, like Barbara Starfield said, is the key to that. So to me, this is the linchpin issue. And in mobilizing a response, and Ashley, we didn't talk about Alan David's article expressing concern that the 25 by 30 goals are too ambitious. I'm writing a piece. I forget if I shared it with you, the first draft, but I think this is the linchpin issue. And I think we have to stop doing it alone, and we have to start building coalitions, the business community, patient advocates. You know, if you've got people out there advocating for improved health for people with disabilities, more family physicians is what one of the key things that's needed. You just go down a list like that, but we're not talking to them, and they're not understanding that family physicians are critical to what they want. And I think that's part of what we have to start selling too. So anyway, I'll get off my soapbox. I'll dictate my notes and share them with everybody. Michael, with his skill, will put together our meeting minutes, and the report will come out. And we will carry on. We will endeavor to endeavor, as they say.
So thank you all so much for joining us. And one of the things that we have a next step with the October meeting, and we'll iron out those details. But I was also thinking today, with people coming and going the way they needed to for other conflicts, that maybe for our next meeting, kind of post-October, we think about just a shorter meeting to really allow people to carve out some time to be together as a whole group and continue these really valuable discussions. It's hard because there's so many best practices to share and so many folks that we want to bring in to present, but to balance that with everything else everybody's got on their plate, I was thinking maybe we should shrink these meetings to 2 or 2.5 hours. But I appreciate all of you and your time that you put in today. It was really nice to meet you, Hema, and I'm glad to have you on board.
Thank you. This was a really good, as I said, eye-opener. It was wonderful to listen to all the rich discussions you were having. And for my part, I can do what I could, for my clinic and maybe in my local area. The problem which I go regularly to Case Western University, and I cannot see how few students choose family medicine. And I think the interest needs to start when you're in the first year, second year, because by third year, fourth year, already decided what they want to do. And the last 2 years, I've had a small group. I facilitate a small group, and none of the 18 students decided to go to family medicine. It's very disheartening. And so just to, and I have a lot of students who come from even neo-med, like even 4 or 5 years back, we had a lot of these neo-med students going to family medicine. But just the other day, I heard one of the neo-med students saying, guess what, how many students matched in ophthalmology? We got 5 students getting into ophthalmology. So even neo-med students, I'm not sure how many of them are going to family medicine. So I think it needs to, as I heard from the discussion, needs to come from the medical school dean, having an interest group in medical school, and also right from high school, trying to increase interest to do family medicine. And I think bottom line, as a physician, being for almost 30 years as a physician, clinical faculty, just the pay structure in medical students, they come up with a lot of loans, and also sometimes they choose certain specialties, the other specialty probably even because of the pay, not equal between different specialties. So that's also another reason. And also the amount of work a primary care physician does in terms of paperwork and administrative work. Even after clinic, the work never ends, right? So I think all this is factored in for, I think, just getting more support staff for faculty in primary care. I think for all physicians, but definitely for family medicine, primary care, just having people to support the work we do, because a lot of us take work after home. So I think medical students, when they rotate, they see like how different specialties are, and so how to make life more easier for family physicians so that many more medical students will be happy to come in and do. So maybe making better pay, giving more support for the physicians might, motivate medical students to, do residency in family medicine. Just my piece of my experience I'm just sharing with everybody, because I'm almost full-time clinical. I've been at Metro since 2004. So I know like how life is, to do primary care.
Yeah, it's hard work, but it's good work.
Yeah.
And I think what's really hard is in our current structure of medical education is to show people what those relationships are like and the rewards that we get from caring for people and having those relationships over time. It's really hard. You bring up ophthalmology, which is just a pet peeve of mine. I had this patient recently, you need 4 going into ophthalmology because they have focused so much. So I had a patient go to optometry who sent her to ophthalmology, who sent her to a retina specialist. And then it's like somebody else to do the injections. And it's just like, well, that's 4 eye doctors you had to see like before we could get you what you needed. It's unbelievable, the subspecialization and how narrow, and how I was describing it to her is that like once you go from being okay with uncertainty and generalism and decide you're going to specialize, the vast amount of medical knowledge there is means that you have to sub specialize just to feel comfortable with knowing everything. There has to be a degree of uncertainty that you're comfortable with. But once people decide they want to specialize, it's going to get down to like the left hip surgeon. And then
And-
they have to go to somebody else for the right hip.
And there's fewer and fewer primary care physicians because most of my patients keep telling me, you're not going to retire, right? You're not going to retire. You're going to be there for another 10 years. You're going to be there for another 15 years because they just worried that they're not going to have a doctor to take care of them. Like their primary care. And so one of my patients said her daughter is 3 years old. So she said, will you be there another 10 years till my daughter turns 16 or 13 years till she finishes high school? I told her, yes, I'll be there as long as I'm healthy and alive. So I'll take care. I don't want to retire because I like what I'm doing. So
Yeah, and I think it is just really hard for students to understand that. I think the longitudinal integrated models of curriculum are helpful in that. And that's what we're hoping to move towards in our school, that it's really hard. And I mean, how can you in a couple weeks or even 4 weeks in a family medicine office have any sense of the joy that we have in practice?
Yeah, I agree.
So we got to hear your stories, Stacy. Tell your stories.
We'll see. We'll see. All right. Well, we are past time. Thank you all again. And I look forward to our next plans and hopefully being together in Pittsburgh in the fall.
Great. Thank you.
Thank you very
Thank
much.
you. Take care. Good night.
you.